Hi, this is Salman Alana and Manos Berlakis, and this is case 198 for the Manual of CTO Interventions. This is a case showing that in some cases it takes time to complete the various steps of CTO PCI, emphasizing the importance of being patient and collected during these attempts. The patient was an elderly gentleman who presented with significant angina that was refractory to medications and was found to have inferior and inferolateral ischemia. Coronary angiography showed no significant disease in the left coronary system. There were good collaterals filling the PDA and the distal right coronary artery. And the RCA was a CTO, heavily calcified vessel, CTO in the middle segment with a large acute marginal branch originating next to the proximal cap. And this actually can be misinterpreted. We did misinterpret it on original viewing as a potential continuation of the RCA, but in reality that was an acute marginal branch. So the patient came for CTO PCI. We used a radial femoral access, which is our common approach for CTO PCI these days. We used the right radial to engage the left, but had a lot of difficulty with subclavian tortuosity. This problem was solved by using a 75 centimeter long R2P sheath that straightened out the tortuosity, and after doing that, we were able to engage the left main using an EBU 4O guide catheter. For the right coronary artery, we used a 7 French AL 0.75 guide that was inserted using femoral access. And this is the dual injection. Once again, we have a CTO of the mid-RCA. This is a heavily calcified vessel. There are both epicardials as well as septal collaterals filling the posterolateral and the PDA. Another view trying to better understand the collaterals. Maybe not 100% continuous connection between the LAD and the RCA, but those septals look promising. And to summarize, we do have an RCA CTO with an ambiguous cap at the takeoff of this large acute marginal. The occlusion length appears to be short, but there is heavy calcification, both proximal and within the occlusion, and distal to the occlusion. The distal vessel had some disease, but it was of good caliber. And then there were both epicardial as well as septal collaterals filling the distal vessel. Based on this, our approach was to first try Antegrade wiring. If it didn't work, ADR. If it didn't work, retrograde through septal collaterals. So we started with the turnpike LP. Filter XTA did not make much progress. We rapidly switched to a Gladius Mongo, but this also had difficulty advancing. We're still actually within the proximal true lumen here. So we changed this. We used the Gaia Next 2 wire that it advanced through this area of the proximal to mid-right coronary artery, further down all the way to the proximal cap. But then eventually it went into this large acute marginal branch. We decided to use parallel wiring, so we used the Sasuke dual lumen microcatheter. We did a small contrast ejection, see if we could better understand the anatomy, but that was not very helpful. And then we used also another wire, a Gladius Mongo, that seemed to be advancing along the course of the distal RCA, but it was outside the lumen in the extraplaque position. So we decided to knuckle it, so we advanced the Gladius Mongo knuckle, but when we did that, the movement of the wire was not quite in sync with the distal RCA. Here it looks like it's moving in a different plane. And this is one of the challenges with ADR. We need to make sure in orthogonal projections that our wire is indeed where we think it is based on the one projection. And in this case, we were not, so we pulled back the Gladius Mongo wire and tried to redirect it. And this time, the loop seemed to advance along the course of the vessel. And now we've confirmed with contralateral injection that sure enough, now we're dancing with the vessel. We're clearly in the extraplaque position next to the distal true lumen. So our next plan here was to advance the Stingray balloon and do re-entry. But this was not as easy as planned. The Stingray did not go. We switched to the Gladius Mongo for a Miracle 3 wire. Still, it wouldn't go. We did predilatation using a 1.0 millimeter balloon. That still did not work. And we also used a 7 French Trapliner that we inchwormed all the way to the mid-RCA, both for support, but also to decrease the chance of hematoma formation distally. So this took a long time. This was actually a live case for TCT 2022, and this stage, going from having extraplaque wire distally delivering the Stingray, took several minutes and we ran out of transmission time, which illustrates the fact that CTO PCI cannot be unpredictable and some of the steps can take a significant amount of time. The final success was achieved by using a second Stingray balloon. What we have found is that the Stingray balloon can get deformed and can be very hard to deliver sometimes. So when that happens, it is best to actually get a new Stingray balloon instead of trying to use the old one. And in our case, indeed, the new one much more easily crossed into the extraplaque space more distally. We then used the stick and drive technique. This is a Gaia third wire. And when we did the contralateral injection, we can see this in the true lumen. It was in a small branch here. So during the injection, we pulled it back and redirected. We have found this a useful technique to move the wire while we're injecting on the contralateral vessel, because then we can see if it's moving easily and if it's moving along the course of the vessel. Given the calcification proximally, we switched for a Viper Flex tip wire and did multiple rounds of orbital atherectomy in the proximal RCA. We did not go distally given the dissection in that area. And then we switched for a workhorse guide wire. We did multiple balloon dilatations that showed good expansion. And then we did revascular ultrasound that demonstrated some calcification, but it was not circumferential. So we ended up placing stents all the way from the distal RCA to the ostium of the right coronary artery. And then we did IVUS showing some under expansion, this oval deformation, and that's why we post-dilated with a 3.5 millimeter NC balloon. And after doing that, we got some better expansion. And we also used the Ostial Flash balloon, which is specifically designed to flare the stent struts of aorto-ostial stents. And this was the final result. We did get a nice flow distally. There's some diffuse disease in the distal RCA, which we elected not to treat because often the vessel will enlarge over time with better blood flow. And the patient did well. Several lessons from this case. The first one is that severe calcification can be challenging, and it's challenging to cross with the wire, but it's also challenging to deliver equipment and to expand the stent. Second, about trusting the knuckle, a common saying amongst the CTO PCI operators. Yes, the knuckle usually is something to be trusted, but like everything else, you should trust but verify. Because I think in our case, at some point the Gladius Mongo went into a small branch, and had we not verified, it could have caused a significant perforation. Third one, if there is difficulty with delivering the Stingray balloon, the solutions include improving support, which was done with a Trapliner in our case, using preparation of the vessel with ideally a small balloon dilatation, a 1.0 millimeter Sapphire in our case, and finally sometimes by using a new Stingray balloon, because the original Stingray balloon may become deformed when advanced through areas that have significant stenosis. And finally, we did use the Ostial Flash balloon for flaring the struts protruding into the aorta so that subsequent engagement of the vessel can be facilitated. Overall, CTO PCI can take some time. In this case, the most prolonged step was delivering the Stingray to the re-entry zone. That took several minutes and several maneuvers, but having a systematic approach and being patient was key to achieving a final success. Thank you.